Hi, everyone. Thank you for joining us today for the Alumni Weekend event, Simulation and Care at our simulation hospital. I am going to turn it over to the amazing team at ZIEL to go ahead and get us started today.
All right, thanks so much, Michaela. Oops. So I want to give, first of all, a really big thank you to the team at Alumni Relations for hosting this really big Alumni Weekend event and for inviting us to join. It really is a pleasure to have the opportunity to highlight some of the transformative medical simulation going on here at KU. So thanks again. So my name is Zamierowski. I am a simulation program coordinator at the Zamierowski Institute for Experiential Learning, better known as ZIEL. And I'll be co-facilitating the panel today with Emily Diederich. Emily is a pulmonary critical care doctor. She's the founding director for ZIEL and serves as the assistant vice chancellor of simulation for KU Med. And we have a really stellar lineup of panelists today. So kicking us off will be Kelli Reiling Ott. She is a clinical assistant professor in the School of Health Professions, and she'll be highlighting the ways that simulation has transformed education in the occupational therapy department. And after that, we'll hear from Mike Rouse, who is the internal medicine clerkship co-director and an assistant professor in the School of Medicine. And he'll be giving us a glimpse into a pioneering longitudinal simulation curriculum for KU Med students. And lastly, we'll hear from Laura Klenke-Borgmann, a clinical assistant professor in the School of Nursing, who will be presenting on how simulation can give nursing students hands-on experience for one of the most unnerving situations they face on the job. So for the panel today, each panelist is going to give a short presentation. And while they're talking, please do go ahead and enter any questions that you have for the panelists into the chat. Emily and I will be monitoring the chat and working to incorporate your questions into the discussion portion, which Emily will facilitate after each panelist presentation. So I'll go ahead and turn it over to Emily to get us started.
Great. Hello, it's such a pleasure to be here and thanks for joining us for Alumni Weekend. I just wanted to say a couple words since you're not able to be here in person. You can see on the left upper slide the beautiful health education building that opened in 2017, and just wanted to highlight that the top 3 floors of that 5-floor building are all space for simulation training and practice for healthcare students and as well as healthcare clinicians and providers at the University of Kansas Health System. So it's really a national class, international class, state-of-the-art building to really help make sure that we're all ready to take care of the patients that we need to. And I think, you know, while it's an impressive structure from the outside, what's most impressive is what happens on the inside. You'll see the bottom right photo is kind of the entry to what we call the simulation hospital, which is on the 4th floor. And it is really quite an authentic 6-bed hospital with a nursing station and a med station, a laboratory space, pharmacy space that sits just below the home environment that we'll hear Kelli talk about today. And what you'll see if we were able to zoom in on the photo on the right, the tagline, which is transforming learning, collaboration, and care. So the faculty that have joined us today are all really walking that walk and within their own spheres, just, you know, changing the shape of healthcare really by the lives they're touching in these students. So I think you'll find the same as you get to hear them share. So I'm going to kick it over to Kelli to tell us about the work she's doing in occupational therapy.
Yeah, thank you, everyone. I am excited to be here representing the School of Health Professions, specifically the Occupational Therapy Education Department. So what I'd like to do, oops, I'm not getting it to advance, sorry. Okay. All right. There we go. I would like to start off with kind of the situation. So picture this. You are trying to teach students how to complete tub transfers without a tub. Or think about preparing students to encounter a situation in an individual's environment without ever having been exposed previously. With that being said, thank you. With that being said, I would like to kind of give you a little bit of background. In the fall of 2020, the Occupational Therapy Education Department welcomed their first class of entry-level doctoral students. Through curricular revisions, the program was provided an opportunity to partner with ZIEL to provide simulated learning experiences. This was to build on our nationally recognized curriculum, and we wanted to supplement these learning experiences that were already being taught in the classroom and lab. And what you see here on the screen is actually a picture of our classroom and lab. It's in these environments which the experiences were a little bit more contrived, and the procedural aspects of the learning experiences were not always able to involve the degree of detail needed to create a systematic approach. Also, what often occurred is that faculty were being asked to serve as both the evaluator and the actor in these experiences. Or if we were lucky, we were able to get student volunteers to assist. So consider this. How can you imagine the challenge when you're trying to play dual roles while being the actor, but also trying to evaluate the experience? Thank you. So presently, the Occupational Therapy Education Department has 3 simulation experiences. We have the Transfer Procedural Sim, the Home Safety Sim, and the Code Blue Procedural Sim. I'll go through each one with a little bit of detail. The first is our Transfer Procedural Sim, and this is where students are placed in pairs or trios to follow instructional guides as they perform 4 different transfers. Each of the transfers grow in complexity, with the most complex involving the student's ability to interact with IV lines and a catheter. The next simulation experience is our Home Safety Sim. This is an opportunity for students to be paired, to be within the home environment, working with a client actor to complete a home safety evaluation. And this is a picture of what that home environment will represent. The third and probably most recent simulation to be added is the Code Blue procedural simulation. With this particular simulation, it involves approximately 150 students from physical therapy, speech language pathology, and the occupational therapy department. As you're seeing here, the students are able to go through the procedures of Code Blue. However, I think the most highlight of this experience is when they are able to really work together as a team and communicate. So now I'd like to go into really a little bit about the benefits of the ZIEL experiences. So besides being able to address content standards that have been required for program accreditation, the benefits of the ZIEL experiences have provided students an opportunity to learn beside other peers and interprofessional learners, which is really the beginning of collaboration. However, I believe that what you will see in the following video will provide more detail than I can do.
So often we are so limited just doing things in a classroom environment. And with the students that we work with, we really emphasize authentic context, and to be able to come into an authentic context and basically plan it so that we get the procedures down and we get the experiences there so that they're able to get a taste of what happens in real world before they actually go out to real world is completely invaluable.
I think this experience is so important because it gives students the opportunity to be with a real person. And students always ask, can we be with real people? And this gives that opportunity for them to actually work with a client, but it's also in a safe space. And I think the other thing that is the most important is that it gives an opportunity for students to build confidence. Students are always worried about being perfect, and this offers the opportunity to not be perfect and that it's okay. they're safe, they're in a good space, and they get to try out the things that we've done in class.
It's really awesome to be able to tie in what we're learning into the classroom into a real life experience. It's nice to be able to take all the information that we've been learning throughout our time here and to be able to put it into practice before we actually go out and do our field work and clinicals.
Having the opportunity to practice and get feedback in real time is so essential to becoming a better student and becoming a better practitioner as we move forward.
It definitely challenges you to apply what you're learning in lectures, because it's easy to be in class and then hearing examples from professors who have this real life experience and saying, oh yeah, I would do that, or of course that, that makes sense in the moment when you're in class and you have all of these materials and everybody with you for support. And then when you get in these simulations and you get there and it's completely different than how you envisioned it, because you don't have a paper giving you the full case and immediately everything that's going on. Having that experience and being able to allow for these mistakes and learning opportunities during the simulation, as opposed to outside in the real world when you're actually being a practitioner, is very valuable.
The simulations allow an opportunity to exercise the skills that you can't really learn from a textbook or from our great professors. You really need a person in an environment to practice on, with the safety of having your professors as guide points in the simulation and your classmates as fellow learners and mentors through the process.
Collaborating with other people really gives you so many different perspectives as to how we can best do that for students, how we can provide them with the best experience. So the actress, other interprofessional collaboration, they all come together and it just sets up this beautiful experience for students. So it was amazing.
Kelli, it was so great to hear from the students, and so great to see that your awesome work highlighted there. I wondered, so audience, please go ahead, and if you have questions, type them into the chat. We're keeping an eye on it. And also, Kelli, in the meantime, I'd love to hear from you just what was the process of developing this simulation experience like for you, and what can you give us a little backstage look at what goes into that?
Yeah, absolutely. And just kind of really, I think what probably needs to kind of be put out there is it takes much longer than you think. In the past, I think it's so easy for us as faculty to say, oh, we can do this, we can get it done in a day. And really the process really can be up to a year before the simulation can take place, because it's very intentional in developing what are those specific learning objectives you're trying to meet, and considering all possibilities. And so I had a great appreciation of that, just developing, the procedural sim as well as being part of the immersive sim building. In that with the procedural, there's so much that gets put into the instructional guides as to what is the best practice for completing a transfer this way. And then in that environment is when you get to kind of work through the what ifs and the nuances within. But what was, I think, the most beneficial to me was having the team, because I know OT content, but I'm not the logistics person. And so having that support in, hey, did you think about this? And hey, did you think about that? And then really looking at, especially when you're going into different types of environments, as we've been able to do, is, okay, let's set it up this way to give students an opportunity to interact with this, and let's consider this. And so that's where I felt it was so beneficial, because you really have that sounding board that everybody's bringing expertise to the table.
That's awesome. I have one follow-up question just to get a little more detail, because I'm a critical care physician. So when you're talking about, can you give us a little micro example? I think I remember seeing your instructor guide about the nuance of transfer, how you safely, just as a patient, get someone from, whether it's bed to commode. Because there's so much more that goes into it than a critical care doctor might realize.
Absolutely. And there's so many steps, and you don't get that appreciation until you're actually building that instructional guide. And so what, for each of the 4 transfers that we created, or not really created, the instructional guides we created for the transfers, we had to do step-by-step detail that also included cues as to what might you say to the individual who doesn't understand your medical jargon in order to get them to that next step. And in doing that, we provided a lot of pictures. We went through the walkthroughs to really make sure everything was going to go as planned. And then during the time of, that's where we got to really kind of do that finessing on technique. So the students, what we had the students do as prep work is we had our lab environments where they were introduced to the guides and they got to work through all the tools that they would be using during the simulation. And then at time of sim is where they were paired with faculty that were there kind of being coaches, but it was really them kind of guiding the experience and us providing those little, okay, this is how you might finesse it here. And this is, you know, what you would do in this type of situation, knowing that what I really wanted to get out of it for them is that they had it as far as what is my next step? What do I need to be considering at each point when? And then if anything out of the ordinary occurred, they knew how to handle it. So yeah. So
that's great.
Really, yeah.
That, and I'm sure all the faculty here, and you know, I know there are so many graduates of KU on this webinar with us, and I think one real powerful thing about simulation is when the expert faculty or clinician goes to teach it, having to design it, you start to realize all the decisions and expertise in your head that happens kind of automatically, and it provides a mechanism to kind of unpack that. So, you know, very novice students can practice it, whereby, you know, conventional wisdom might be, well, those are the sort of things you learn with experience. And, you know, I think the counter argument is, well, let's learn that by experience here in the safe environment where our patients aren't at risk. And so, absolutely, you know, thanks for those comments are really rich.
Yeah, yeah. And what many students have responded is that they love the feedback in time.
Awesome. Mm-hmm. Awesome. I see Krista Eccles, who's a previous student in the program before simulation was incorporated. So it sounds like she would have been someone, Kelly, that was a student but playing the role of an actor of the patient. Can you say more about Krista? I think it's just highlighting how important and impactful that was. Maybe you could comment on that, and then we'll transition to
yeah. I think it can kind of go both ways. You know, the experiences of trying to do a checkout or work through learning the transfers when you have the faculty playing both roles, and how it can get very confusing going back and forth. Yeah. But then even for when we had student volunteers, with the experiences that we have as faculty, we get to see how things look, you know, so when we're putting individuals in scenarios, because oftentimes with the transfers, we are placing the students in scenarios of somebody following a hip replacement, somebody that has paralysis from the waist down, somebody who has one-sided weakness. And so faculty can kind of simulate those experiences, but asking students to come in where they haven't had a lot of clinical experiences quite yet, that can be kind of confusing. And so that's where I feel like the simulations have really helped, especially when we've been able to bring in actors to really kind of guide those experiences, because often the students were like, I didn't know that was an actor. I really felt like I was interacting with someone that, you know, it was somebody I was supposed to see that day, you know, and so really part of that fiction contract and really creating that safe container for learning.
That's awesome. I mean, there's a lot of synergy between the disciplines of simulation and acting and movie making, kind of that front stage, backstage. And certainly acting is a profession for a reason. And insofar as we're trying to emulate the interpersonal connections with our patients too, it sure is rich to have that authenticity. Okay, good. Well, thank you so much, Kelly. That's really, really awesome, impressive work you've done, really on the cutting edge nationally of occupational therapy education. And I'd love to kick it to Dr. Mike Rouse, who's going to talk to us about some work that he's been doing, you know, with the School of Medicine, but that's also included this school, the Department of Respiratory Therapy, so respiratory therapy students and clinical lab science students and nursing students over the years. So it's been a really great kind of interprofessional program. Mike, to you.
All righty, I'm going to time myself and try to talk slow and clear, because that's not what I'm known for. But that was great. I really enjoyed that patient safety and their home simulation. It seemed really exciting and cool. And I'm thinking of a lot of themes that I'm about to talk about, of authenticity collaboration and all of that, which is kind of our goal too. So currently my biggest role for the medical school in simulation is through a program called STAT, which we're going to talk about, which is a longitudinal program that's really focused initially on the first 2 years of school, but has expanded into their clerkship environments. And our focus is to help students prepare for patients with either urgent, emergent conditions, or they're declining and we need to act. And this really strong recognition that once students start participating in patient care, they are very likely going to be surrounded by other healthcare teams or teams of their colleagues that they need to reach out to, engage, and help escalate so that they can all work to helping that patient. So that's been a pretty exciting program, and it starts early. We're doing it right now for the first year. So we're just a few weeks in, trying to teach them how to be good communicators for the sake of patient care. And so for just the purpose of a picture being worth 1,000 words, see if I can go on the next slide or not here. There we go. I'll try this video here because to me it really summarized some pertinent and very shared thinking I think a lot of us have had working in healthcare.
So what's it like being a young hotshot doctor?
It's like, did you ever go see a movie that everyone told you was great, and then because of all those expectations, you ended up totally disappointed?
Movies nowadays have too many special effects.
Yeah, that was pretty much my point.
My first code. See, here's how it works. Someone's heart fails, they beep everyone. The first doctor in has to run the room, tell everyone what to do, basically decide if the patient lives or dies. What, am I crazy?
You chicken.
Don't worry about the patient. Turk was already there, learning by doing.
Charge, clear!
Plus, it turns out the guy was just sleeping, attached to a faulty monitor.
Okay.
So what's it?
So that was from Scrubs season 1, episode 1. So the first episode ever, and it's entitled My First Day. And so when you start to talk to healthcare professionals of any background, there's likely an early story when they were first starting out of just being absolutely petrified by the responsibility that just a day or two before they were craving so much. And so as a faculty, I am a hospitalist, so I exclusively do Medicaid or general medicine on the inpatient side, where our patients are a little too sick to be home, but not quite sick enough for the ICU. And so our residents are often charged with carrying the code pages just like that. And looking at this video, that was JD on his first night. He's entitled or expected to run a full code that could be life-saving for a patient. His first thought was to run to a closet after thinking, am I crazy? But he was not the only one in the closet. So there was another intern feeling the exact same stress. And then his colleague Turk was learning by doing and was actually being active, which is great. But the team that was in the room with him, I believe, was at least 2 other people shocking a patient, and none of them really taking the time to check a pulse or check for breathing. And so to me, a lot of this is funny, but also very, very true. When I think about my life and my career, July 1st was just recent. We had a series of, once again, lots of new interns carrying new pagers, new senior residents stepping from their intern role into a new position, new students who are monthly, new patients every day. And even if there aren't new nurses, new techs, and new RTs, they're probably going to be new to me. And so on any given day, I don't think in my 7 years yet, I've had the same team twice. And so it's just imperative to know that when new people show up all the time, we have to work really hard to be collaborative, communicate well so we can set expectations and give good patient care. And so part of our care and what we're focusing on in STAT is, well, we would love to avoid the code blue. That is the ultimate goal. They will happen. Sometimes we can't avoid it, but what can we do in the meantime? So leading up to those events, how can we identify problems, gather some information, start early interventions, form the team, and have a plan before things go wrong? And that's really our goal on rounds, and that's our goal in the STAT program too. What's really important too, especially when we have early learners like students, is that we want to prepare them for things that might be low frequency or high stakes, right? So we hope you don't see a lot of, or you may see a lot of acute appendicitis. It may not be something you see frequently, but what is sort of the can't miss things? Sometimes it's because of inadequate exposure that makes it tough for you to get proficient at, or oftentimes things outside of BLS and ACLS have really vague or shifting guidelines. So it's important, it's a good opportunity to practice that, especially for our students. There's a large population of people that say, I don't really crave acute declining patients, and that's okay, but the patients will still find a way to find them. We have lots of my colleagues that are in the clinics, and it is amazing how sick people can show up when they're there in the clinics, and they actually need to be even probably more primed and ready to go because that might happen less frequently. And then we just know that teamwork is really a real big root cause of gaps in healthcare, and that I have not been in a single room with any patient that's declining where I've been able to handle things on my own. So I need to recruit, I need to let people know what I'm thinking so we can advance care for that patient, and that's the ultimate goal. And this is a big deal. So this is not just Mike Rouse saying something. This is, sorry, getting a little happy here. The EPA is focusing on care for an urgent emergent patient and working as an interprofessional team. Our EPAs that are currently supposed to be practice ready day one of residency, which to us on the medical school side means that it needs to be pretty well established before we even get to that point. And that's why for us, this longitudinal program is such a great opportunity to try different situations, have the patient care, and problems get more and more complex, but at the same time providing a great opportunity to do that in a safe environment and using skills of communication that are building on each other each time. And it's pretty amazing what our students can do. So the last thing I'll lead you with, if I have enough time, Mary, is this is just to contrast a little bit of a code that's actually being run by second-year students. So well beyond the scope of what I could even consider doing at their time, but just taking note about how well they're communicating and focusing around the patient care.
I don't know, call. Go ahead and call for blue. Nick, you call operator.
ZIEL hospital operator.
4215. I'm gonna have you just stay with the oxygen. So once we need to use the defibrillator, you call them. Okay. Okay, Nick, can you go ahead and check her chart to make sure that she's full code?
She's full code.
Okay, thank you.
Stand clear.
Defibrillator's on.
Wait, hold on.
Oxygen's off. Everybody clear?
Clear.
Stop.
Perform CPR.
Nick, I'll have you replace please once the oxygen's back on. Is it on?
Did we call operator?
This was the culmination of a large simulation where they all came together, working as a team to identify the problem, start some treatments. When the patient deviated and ultimately ended up in a code situation, how quickly they were able to transition, identify clear roles, and have great communication to make sure things were getting done. So it's pretty mind-blowing to think that a group of second-year students is operating at such high proficiency and working so well. None of our students ended up in closets, hiding from the code situation. And so it's been a really awesome experience.
Great, Mike. Thank you. That's awesome. Thanks for the video. Hey, Mike, you spend so much of your time rounding on the wards with students and residents in your academic teaching role. And I'm curious to kind of hear from you how you, like, why do the sim when they get to rotate on the wards? Like, what does simulation offer that they can't get in their third year on clerkships? And how do they synergize with each other, if so?
For me, the biggest difference is probably our use of debriefing, which there's probably a million different ways that any of their faculty attendings or residents may do or approach a situation, but it really allows us a time to really break down those best practices, which I heard mentioned earlier, making sure that if something does happen, they can try a role or position. If they make mistakes, which we actually kind of encourage, we just try it again. And so those high stakes situations become very manageable. And then if they do feel really bad about something, or they're not sure if they did the right thing, that's the time when the faculty come into support and give them good advice. We try it again. And they often will hear good support from their colleagues and other people that are participating in the simulation. The ward environment, when this happens, we tend to pick up and move on very quickly. We usually don't even allow our own teams time to decompress. And so we risk internalizing problems and maybe getting or having a negative impact even on other patients as we care the rest of the day.
Awesome. Let's see, we have a question from the audience. Do other teams also use simulation along with the medical students? Yeah, can you talk a little bit about the interprofessional work?
Yeah, so we really crave the interprofessional work. Our faculty is this huge pool of people, and we just spent 4 hours with various people trying to develop cases. In the past, we've had School of Nursing, Dana Baker with the Allied Health and Clinical Lab Sciences. We've done the School of Pharmacy. Who else am I missing here? Respiratory therapy is very active. And that's a fantastic way for people in the medical school perspective to see what other people can do, what's their scope of practice, see what they're really good at. And usually our students are pretty much in awe with the skill sets of other schools. And they really, really appreciate getting that insight. And learning from their faculty too, I think has been a profound experience that I did not get in school either.
Awesome. Another question, Mike, something you said I agree with, but I'd love to hear you talk more about that. You said, actually, we actually hope they fail. What do you mean by that, and how does that impact the learning?
Well, what we hope is when they come up to the ZIEL hospital, they know they're not going to get an A or B or C or D. We do a lot of prep work to establish a safe container, so that way they know that if they're in a position where something's uncomfortable or challenging, that's right where we want them to be for the day. And it's all about failing for the sake of learning. When Turk was learning by doing on the wards, he shocked the patient because there was not a pulse. That is a great thing to practice and learn and correct in the sim hospital. Our hope is if they are going to make errors, let's make those now. So that way your first encounter where you're not sure is not with a real patient on the ward. So let's get all that bad stuff out now. You're still going to make mistakes as a graduate, but let's really try to focus on how we can learn safely.
Awesome. Mike, I see a great question. It kind of ties together the last two. So the question is, do you use simulation experiences as part of new hire orientations? Maybe you could talk about the health systems effort to use nurses and integrate with the medical student work.
Absolutely. And so for new hires, that to me goes back to when we have our graduate medical education. So when these folks show up July 1st, they've actually been through a few things from KU from our perspective. So we do a lot of co-blue training, very deliberately interprofessional with both standard traditionally medicine units that we work on a lot, and hybrid with the co-blue teams and their first responders. Again, the same process is how do we take these ad hoc teams of really smart people and make sure the communication's there, and practice exactly what we want them to do on the wards. And it's okay to fail there too. We keep learning from each other, same strategy, same structure, debrief, try again. So yeah, that's a great question.
Awesome. Okay. All right, Mike, thanks for sharing. And folks, keep the questions coming in. We may have a little time at the end to leap back to some additional conversations with Kelli and Mike, but at this time, we're going to kick it to Dr. Laura Klenke-Borgmann to talk to us about her awesome work in the School of Nursing to help prepare students for very challenging clinical situation.
All right, good morning, everyone. Hi, I am Laura Klenke-Borgmann. I am a clinical assistant professor in the School of Nursing. And I am actually going to describe to you today an end-of-life simulation that was conducted in the ZIEL hospital last year with our senior fourth-year nursing students. So just to kind of give you a little bit of background and context, the name of this simulation that these senior nursing students experienced was called the Barney Smith experience, named essentially after the simulated patient. And really this came about because one of the most daunting experiences for nursing students and new nurses is the death of a patient. And honestly, students don't get a lot of hands-on experience with an actively dying patient in school and in clinical. In fact, a lot of the time, they're actually kind of pushed to the back or even maybe out of the room in those situations in clinical during school. And so this simulation experience for these fourth-year senior nursing students was really designed to provide a safe place for new nurses to experientially learn how to have difficult conversations with patients and their families regarding advanced directives, do not resuscitate decisions, what the signs of impending death clinically look like, and also working with families regarding differing opinions and thoughts at the bedside. And also truly how to actively manage a dying patient for nurses in terms of providing comfort measures, medication administration for pain and secretions, and things like that. So the objectives for this experience for these nursing students was really to have them be able to meet the emotional and spiritual and physical needs of a dying patient and their family. They would get experience conducting a spiritual assessment of the patient and family, and then also be able to get some experiential practice with clinically managing symptoms of that dying patient. We're having some issues with the slides here, one second. So we achieved those objectives through a 2-hour immersive session for these nursing students. The students would arrive to the sim hospital, and they'd get sort of an orientation and a kind of description about what that 2-hour session would look like. And then we'd actually start our first case. There's 2 cases in this experience. The first case is about 10 minutes in length. We would ask for 2 of the nursing students to volunteer to be the nurses caring for Barney Smith. And in this first case, they're going to meet Barney. And so that we have 2 student volunteers actually caring for Barney, and the other nursing students in the group, about 6 or so, would actually just be observing the case. And they get to meet Barney. They find out that he's a 68-year-old man with a history of cancer, and he's coming to the hospital for management of his pain and his shortness of breath. And while in the hospital there with the nurses, he decides that he wants to become do not resuscitate. He also has a really supportive caregiver daughter at the bedside during this case as well. And so during this case, he is alert and oriented, and the nurses have to provide education about what it means to become a DNAR, to explain comfort care, and really support the patient and daughter in making that decision. So really the main focus of this first case for the nurses is communication and education of the patient and family during this really difficult time. And at the end of the case, then we end with spending some time debriefing with the students on how it went and how it felt and some takeaways that they learned from this really important experience. And then the second case in this 2-hour session, again, we asked 2 new students, volunteers, to participate as the nurses for Barney. And this time in this second case, we've kind of fast forwarded the case a couple of days. So now as the nurses take over care of Barney, they notice that his condition has worsened quite considerably. He's unconscious. He is actively dying, and the nurses must now manage his comfort and his secretions and support his daughters who are at the bedside. One of the daughters at the bedside is very supportive of the decisions that have been made. Another one at the bedside is having difficulty coming to grips with her father's state and the decisions that were made. And honestly, at the end of this second case, Barney does die, and the nurses are caring for that really intense experience as part of that case. And then just like in the first case, we debrief with them how it felt, how it went, and some takeaways and some learning that came from experience with the nurses. And as you see here, this is actually a snapshot from one of the sessions last year. And you can see that the patient, Barney, is a high fidelity mannequin, but the daughters at the bedside were actually real people acting. So it really provided a really powerful contextual experience for the nurses to be able to have those in real time conversations with people at the bedside, playing the family members in these difficult times and decisions. And so in summary, this experience holds a lot of value and meaning for 4th-year nursing students. It allowed them to sort of, try on their skills for these very challenging, difficult end-of-life situations that they would find themselves in their own practice in just a few short months after they participated in this case. And the takeaways and the feedback and the evaluation from the students were really positive. Saying things like, oh my gosh, we need more of this type of real world simulation. The best learning experiences come from simulation. Others found the debriefing afterward to be the most helpful and really helped them learn how to have those kind of difficult, awkward conversations with patients and families at times. Again, just kind of noting that it can be really challenging, and getting some experience with that was very powerful. And then I love that last one there, that they learned from these simulations that, you know what, it's okay to not know all the answers all the time, and just being present and being open in these situations for patients and families is really important. And so I thought those were pretty powerful comments from students to be able to share with you today. So thank you very much.
That's great, Laura. This is really one of my favorite simulations in it. Maybe just as a critical care doctor, just seeing the death and dying and knowing how complicated it is. Can you talk about how your students, like what kind of impact it had on your students, kind of working through this pretty intense kind of clinical scenario?
Yeah, absolutely. I think what's interesting about these simulated experiential learning experiences that the nurses have is that it really allows them to contextualize and really, what does it look like? What does it feel like? What's the family going to ask? What kind of really difficult questions? The question that would always come up was, from family member to nurses, how much longer does he have? And that's such a hard question to be asked because we don't know, right? No one has a crystal ball. And so those types of questions were really interesting and powerful for the nurses to be asked those questions. The other thing is that a lot of this content, like in terms of end of life information, had been shared with the students already, like in the coursework in their actual like lecture courses. But there's a big difference between sitting in a classroom and just hearing about these things and hearing an instructor talk about them. There's a big difference between that and then actually having to do it yourself in this very experiential way. And so it really allowed them to kind of contextualize that learning and really realize, oh wow, this is a lot harder than it sounded when I was just sitting in class listening to this.
Yeah. And I guess from my perspective, there's a lot more uncertainty in this type of clinical care than in Code Blue. That's an algorithm. Whereas here, you have one daughter who's kind of feeling on board and one who's struggling. And I mean, how did you prepare yourself, I guess, to be able to coach the students on like the vast possibilities of what they might run into?
Yeah, great question. Again, in a lot of these situations, the thing that we really tried to underline for these students is that there's not necessarily one right way to answer or one right or wrong way to go about it, that how important it was just to be open and honest and transparent. One of the really big things that always came out of the debriefing of this experience was the nursing students saying, I wasn't sure what to say or how much to tell them. I wasn't sure if I could tell them like the truth. And we always really, really encourage them that, yes, tell them the truth, be open and honest, that it's actually better to be open and honest in these difficult conversations of what you know clinically than to say, oh, well, I'm not really sure, and kind of rob the family and the patient from truly understanding the situation and being able to make decisions based on a full understanding of the situation.
That's great. That's really great. I see we have a question from Margaret. Hi, Margaret. Thanks for chiming in. Can you estimate and share the cost in creating and developing lab facilities and programs? Boy, I think the answer is I can't off the top of my head, but I could be happy to, maybe we could connect and follow up about the cost of the facilities. Certainly it was a long-term, I think decade-long goal of the leadership of KUMC to build that building. So it's a pretty substantial, I think, investment. I can speak more, I'm a little more informed about, there's obviously maintenance costs and equipment costs, but to be honest with you, the most important and challenging cost to cover is the time of folks like Kelli, Mike, and Laura. So clinicians and educators, the pressures are greater than ever. People are spread very thin. And like you heard Kelli and all describes, it takes a lot of thoughtfulness and planning to do this well. And so I think it's really a rather universal phenomenon, whether you're teaching students or facilitating a real operating room team training. It's getting folks out of their like revenue generating productive work to do this kind of time intensive education that is, I think the biggest barrier to there being more of it. And it really speaks to the commitment of, many faculty doing this or doing it on top of their other responsibilities because they so believe in it. So I would say for more details about the cost of the building, et cetera, we could maybe connect and offline, but I would say universally the most challenging cost is that of time. Well, thank you panelists and thank you guests. I think one of my reflections just hearing each of you and just seeing really the diversity and what you're teaching, everything from home care transfer to preparing for emergencies to end of life conversations. I think it's just a really glorious kind of sampling of the sorts of things that we need to provide students the opportunity to practice before we trust them to take care of our moms and dads and kids. So, all right, I think with that, we're just about on time, and I think we'll say bid adieu, and thank you so much for joining us for Alumni Weekend, and thanks to the panelists in the Alumni Office for having us. Bye-bye. I don't know if we talk. Is it just us?